This is the urethra, urethra, urethra. I won't see anything up to here. This is urethra. It looks normal when you go from here. We don't know anything is there or not. These are all like on the written only we can see. This is the veru. This is the bladder neck hypertrophy high. Sometimes we go to veru like this. Now we have to empty the bladder. This is the emptying method. You have to aspirate. You have to aspirate keeping in the center. See, some amount of dirty fluid will come. This should be sent for culture. Culture bottle. Directly there we should not put culture bottle. We should take. See there for last 10 years we are doing same. We should keep the culture bottle. If you empty, the bacteria will decrease. Pressure in children will rise. Whatever you wanted to do. Empty, 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 empty. You should take time. It will take time, but you should have patience. Empty, see, collapsing it is. So no suction work. This is the smallest scope. So it has limitation of water coming slowly. So you cannot just rush in and do it. See, this is the now. Don't press the water too much because bladder will fill again fast. Now I will go inside. I will come out on the floor. On the floor I will come out. This is the veru. After veru, we have to see any leaflets are there or not. Yeah, see, normally this is the veru. Just after veru, leaflets, these two leaflets. There is a groove here. That groove will not be there. Can you see a groove here? This groove, this. That groove is a leaflet. Here also there is a groove. Another side. Those grooves are this thing. But these are all already crossed. So this is the membranous area. And if you return only, you will come. Give me, I will fulgurate. Can you put one needle above? So 1 and 10 is the. So there is a needle above. You prick. Wait, not now. After distension, you tighten it. So one person has to hold the tennis on coming out. Camera should be straight. And now this is the bladder neck. You should not do anything. Coagulation mode you have to do. So again, this is the bladder neck. This is the veru. Hold the penis. This is the bladder. This is this thing. So now this respiration stop. This area. This is anteriorly balls will be there, like here. This. Again you have to go inside while coming out beyond the veru. You have to fulgurate like this area, this anterior. It is an imagination. This is a thick wall like thing will be there like this. This is imagination. This is the wall. This groove is the wall. Why there should be groove? There should not be here. See, completely. I'm stretching this patient penis. This just above the veru, just beyond the veru actually. Anteriorly you can leave. Posteriorly I will not leave. The valve is more anterior. We have to remember that valve is more at the anterior. Here. This thick valve will be imaginary valve will be here. Here. See, this is the valve ending. This is the wall thick part. Thick part. One thing we have not done in full bladder, we have not. So this much coagulation, some people say it is not correct. See, it's falling. That falling, this wall falling should be done. This sometimes sphincter also will come. See. You will not see everything here. You have to fulgurate. Okay. Now you have to see whether how the you have to apply like this and press like this. It's coming. Usually it won't come. In the beginning only we might have seen. This blood should not come. So usually in thulium fiber is very ideal. Press water fully. Press water fully. Press fully, no problem. Now I need vision. So this is the veru. Okay, this is the veru. Here this is the wall. This. Can you see this? This mucosal fold, but that is not the obstructing part. Anterior to that, this area is obstructing part. This has to this is fulguration. This is the wall. This is the wall. 5 and 7 you have to fulgurate. At the moment we will stop here because wall fulguration should be done with caution. Now I will stop here. Ramshna, I will stop here because you should know when to stop. See, now press, you have to see how it is coming. So like that it will come. It's a mechanical obstruction. Don't do anything more than that. Just stop it. And next after 6 months, some more. Next after 6 months, some more. Better underdo than overdo it. It took long time to learn this, but now I feel our results are very good. Very good. So I say that I am understanding. Posterior urethral wall is a big subject. There are various types of walls, but the primary criteria I will show here. The bladder, if it is like this, normally, like in adults, posterior urethra is not dilated. There will be a sphincter. There will be a bulbar urethra, and there will be, if it is properly done, RGU and MCUG, it will be like this. Whereas in posterior urethra, 2-3 variations can occur. One is this dilated urethra. You don't see anything here in MCUG like this. There is a lot of difference between these two. Another thing is hypertrophied bladder neck like this and dilated urethra, and then lifting like this. These are the things. Here we don't touch this. It can be abnormal bladder junction. That subject I am not discussing. Primary posterior urethra, if it is dilated, you should suspect posterior urethral wall in MCUG. If it is causing VUJ obstruction with a trabeculated bladder saccule, it says that it is obstructed, and if creatinine is rising, hydrouretronephrosis is there, keep a catheter for 1 week and then go inside and do it. If the patient is normal patient without any problem infection, directly you can do it. Now what we have done now is in posterior urethral wall, it is posterior urethra. Posterior urethra is from where? From here to here, membranous urethra. This is the posterior urethra. Now they are saying membrano-bulbo junction, this also comes under posterior, not anterior. Above the bulbar urethra ending is posterior. In that case, the wall will be here. This is dilated part, and this is the curtain which a hole here. When you go like this, nicely you will go whole and you don't see anything. When you come from above, it will be like this. When you see from the urethra, it is anterior. This is posterior. So you make a fulgurations here, so that half it will be done, so that it will become a hole like this. Then it is enough. That's why one time you should not do. For that you have to make a hole and you have to see from above and do it. That is more logical. But when you make the bladder, when the curtain is like this and opening, and there is a membranous urethra here, when you are going like this, you will see two fold-like things here after the veru. Fold-like things here. This anterior is the real obstructing part. So you coagulate between these two, not this, not the bladder neck. This beyond the veru, after the folds are seen, stay there. Anteriorly you fulgurate here, not completely up to here because sphincter will come. This part I have fulgurated now. Then immediately curtain opening will be like this. It will become like this. So flow immediately open up. But you should not be aggressive doing all the thing up to periphery. Then sphincter incontinence can occur, which is not good. This is the basic concept of posterior. In terms of it is like this, in the paper, the opening is here. Opening is here. Here, this is the opening in posterior urethral valve. This is the curtain. Opening will be like this. So you come above from the bladder and you do this fulguration. See, this much is enough for a good flow. Yes. The same thing if you come like this paper, this is the folds you see. Mm-hmm. From that folds you fulgurated. Mm-hmm. This part is fulgurated. Either ways it is same. This part is fulgurated, but what you see is this folds after the veru. Mm-hmm. Like that. Learned from Dr. K. Ramaraj sir, who has come to our hospital, pediatric urologist, along with Dr. Ramakrishna, who is his student. Both have taught me for 5-6 cases. After that, I attempted slowly, but thulium, previously they used to use electrode cautery. It causes spread of the current, but thulium fiber laser is only 0.4 mm spread. Even if you do 1 millimeter extra, nothing will happen. So here results are better. Our results are definitely better. Now 14 cases we have done. Even if one case stricture forms, even if one case complete obstruction forms, it's a minus, na. We have to immediately alert, na. That did not happen. What do you say, Ramshna? That did not happen. So we are following the same. See, always not only theory, you have to see practical what, for example, enucleation we are doing now with holmium laser. Every patient, if incontinence comes, you have to modify the technique. No patient is incontinent. Only one clot formation formed. Then those 16-18 cases, you are doing correct. When I was using manual bipolar enucleation, even thulium fiber laser, some amount of incontinence was there. Now you clearly define where you want to cut. Why sphincter will be cut? Like that, this surgery is also precision surgery. Casually should not be attempted. Yes. Thank you.